Thank you very much for the invitation to talk. And I'm going to talk on a slightly different slant from Vincenzo. Vincenzo was talking primarily about the live birth trisomies. But this is a fascinating field of NIPT. It's fascinating because it's fast-moving. Our ability to sequence, our ability to do the bioinformatics is continually developing. And because of that, the tests are really advancing quite nicely in the field, and the applications of looking at the whole of the genome and all chromosomes is giving us some interesting questions and hopefully some solutions too. So I am going to put up an odd conflict of interest because normally somebody standing up from a commercial organization, I should have a conflict of interest. I was asked to do this talk 8 or 9 months ago, and I agreed to do this talk. And then in the summer, Cooper Surgical announced that we were stopping doing NIPT. And on the 31st of July, we did our last NIPT sample. And up until that point, we'd done just under 50,000 NIPT samples. So I am not in the NIPT business anymore. I am just scientifically interested, and these are my own personal views and not the views of Cooper Surgical, because Cooper Surgical isn't in NIPT. So a little bit of an odd conflict of interest statement. So exactly the same kind of talk as Vincenzo that everybody gives about NIPT. I'll just make a few subtle points. The same thing is Vincenzo. The NIPT is clearly a test of the cytotrophoblasts that are circulating in the maternal bloodstream in a pregnant woman, and you always have to remember that. And pretty much exactly the same slide as before, and this is just to remind me to say that this field has moved on vastly from the start to where we are now, and the thing to look at is actually we're in a field of really big data. There's millions of tests being run and a large amount of sequencing being done on those millions of tests. And hence, the power of the bioinformatics that you can apply to these tests are really, really quite amazing at the moment. The thing that everybody puts up, it's a screening test, it's not diagnostic, and that's because you're testing the placental material. There are problems with the test. It is a fabulous test, and it has very low false positives, false negatives. It's really, really good, but the biology tends to interfere with it sometimes. And you obviously have confined placental mosaicism, and this is something that we grapple with, especially when you start to look at the chromosomes outside the live birth trisomies. There are things that affect the test, because if you think about it, you're doing 2 tests at once. You're testing the maternal DNA and the fetal DNA. And if there's something wrong with the maternal DNA, it affects what you're looking at in the fetal DNA. So you can have copy number variations in the maternal DNA, and that will perturb your test. You can have maternal mosaicism, unusual, but there. And you can have maternal Turner syndrome. Another one that comes up quite frequently is you can have vanishing twins. Usually what happens is you give somebody a test, and if you provide gender, which we did on request, if you provide gender, they go along and they have their ultrasound, and usually you've said it's a boy and they have a girl. That's almost always the instance when this comes up. And what has happened is there's been a vanishing twin, and the presence of chromosome Y sequences, the test is very, very sensitive to finding chromosome Y. And that twin is effectively being reabsorbed, but there is a small amount of chromosome Y material in the fetal bloodstream. And if you do sequential blood draws over time, it can take somewhere between 5 and 8 weeks for that DNA to be removed from the fetal blood, and eventually the test will become female again. So that's something to consider if you get sex discordance. And of course, you can get true fetal mosaicism. I do know of some cases where people have provided euploid results and there's been an aneuploid fetus, and it does happen. Hence, it's a screening test. Some of the things that we're now able to do with the power of the bioinformatics are really interesting in how we can look at these problems. The other problems, low fetal fraction. I think Vincenzo really kind of nailed a lot of the problems with low fetal fraction. Low fetal fraction can be from maternal issues or high body mass index, all sorts of things. But the bioinformatics has really, really helped with that. Triploidy happens. The test that we ran is the Illumina test, the same test that Vincenzo runs right now, and you can't find triploidy. The SNP tests can, and that's something that is a power of the SNP tests. And of course, confined placental mosaicism the other way around. So there's three real choices in the field as to what you want to do if you're going to do NIPT. You can do what the test that we ran, the test that Vincenzo runs, and these are genome-wide sequencing. So you sequence a shotgun of the whole genome without any selection. And currently, these will detect the live birth trisomies, sex chromosomes, microdeletions, and going on to look at all chromosomes. The power of the sequencing is increasing to such an extent that these tests have really become very, very valuable in a clinical utility sense. You can do focus tests. There's a couple of companies that do focus tests, either by sequencing or using microarrays. And they're useful, particularly for microdeletions. They're very good, seem to be good for the microdeletions and finding triploidy. Less useful if you want to try and look at the whole genome. And finally, there's rolling circle amplification tests that just become available, and they will do trisomies 13, 18, 21. We chose the same test, essentially, as Vincenzo runs. Trisomy 13, 18, 21, sex chromosomes, microdeletions, initially sending it out to Illumina and then running them in-house. Segmental copy analysis that's possible as well, and single or paired end. Single end is what we started off with, and you need to run about 28 to 30 million sequence reads per sample. But if you run the paired end, as Vincenzo described, that drops it down to about 8 million sequence reads. So you can run many more samples for your same sequences, and it does become a bit more efficient for the lab. This is what we had. So we implemented the paired end sequence in February 2017. We had a couple of robots, 4 NextSeqs, and we're running 192 samples a day. We stored every sample. We still have them as well. And we implemented our own in-house pipeline to look at all chromosomes in March this year, which I'll talk a little bit about. So the only thing that I'd say from the paired end, exactly the same as Vincenzo mentioned, it's more accurate, you have to do less sequencing, and it gives you a more robust data. And it has a particularly low failure rate. We had failure rates very analogous to the previously described failure rates. Initially, we started off with our own limit of detection, which we had to develop ourselves, and you had to do that in the early days of this stuff. We progressed in 2017 to using a CE mark test. And the CE mark test is good in that it has no fetal fraction determination to say whether it's failed or not. The only thing that I'd say is negative is that it's a black box, and you don't really find out what's happened to your samples. You just get a result out the other side. It's great in some ways as a diagnostics lab because you've done a CE mark test and you're protected almost from some forms of litigation. As a scientist, it has its challenges. And we got, overall, this wasn't quite the end of the samples we ran, but we had a 1.3% detection rate. Our patient population was possibly a little bit high risk, and hence the sort of numbers that we ended up with. The only other thing I'll mention before I move on to talk about the 24 chromosomes is that we did over 4,000 microdeletion cases, and we had one confirmed positive, which says, I think, all about microdeletions. If I was going to do this again, I think I'd try and say not to do microdeletions. The patients seem to want it, but it's a really poor return. And you can see this is the panel of microdeletions that we used, which was a standard 5 panel from Illumina. So what is the 24 chromosome test? How is it useful? So it aids in the diagnosis of, it aids in the analysis of your results. So you can have copy number changes within the chromosome that is a trisomy that can lead to false positives. And you can start to pick apart whether it's a true result or a false positive result. And then also, the way that the software works, it uses a number of reference chromosomes outside the live birth trisomies, and it normalizes the data internally with those reference chromosomes. And if you get a problem with one of those reference chromosomes, it can make your live birth trisomy result inaccurate. So this is the original algorithm that we used, the NCV, and you have basically a ratio of your trisomy versus a number of other chromosomes. They never tell you which chromosomes it is, and you can make a good assessment of which ones it is. But if we get a positive, and if we have any question marks about the positive, we would go back and look at all the other chromosomes to see if there was an issue there. This is a nice paper from a few years ago, and this actually was looking at some false positive results, and this was using, there's a very nice algorithm the Dutch NIPT consortium have developed called WISE-Condor. This is WISE-Condor, and similar algorithms, and it allows you to look along the chromosome, not just get a CE-marked box result, you get to look along, and you can see that there are underlying maternal copy number variations that are causing the false positive. And you can see here there's a 13, a 21, and another 13 there. And that starts to give you some sensitivity to actually look at the results from within a chromosome. Some of the other things that are interesting to look at, I described before, the maternal CMVs, which showed some examples of here, the maternal autosome mosaicism, and Turner syndrome. Turner syndrome actually is pretty easy to see, because if you have a certain fetal fraction, if you get a 45X that is greater than the fetal fraction, then you know it's maternal, and that's actually something that is pretty easy to spot. The other thing that it's useful for is just general quality control analysis. So the fetal fraction can be detected globally, and Illumina has a very nice fetal fraction. And one of the ways fetal fraction calculation, one of the ways you can confirm how well your fetal fraction is working, it's very easy if it's a male pregnancy, because you can just count the numbers of Ys, and it gives you an estimation of the fetal fraction. But if you do their test, which Vincenzo described, which uses a combination of the size of the DNA, the distribution of the fetal DNA along the genome, it gives you this very nice fetal fraction estimation. And you can then blindly compare that to the chromosome Y estimation of fetal fraction and work out how well they're comparing. And I think Illumina say it's in the high 90s, 97, 98% correlation between those two methods for assessment. So you get a very good fetal fraction. The thing that you can do if you're looking at all the chromosomes, though, is you can look at the fetal fraction of each chromosome, which has its values as well. So the fetal fraction of each chromosome should be the same. And if you see a trisomy and that fetal fraction is not the expected extra percentage compared to the rest of the normal chromosomes, you can start to assess whether that is a true trisomy or not. and this is just an luminous slide. So you can see here that you have your maternal, and here you have in the white boxes the fetal fraction. The fetal fraction should be the same for each chromosome. Then if you have a full trisomy, then you should expect an additional amount in that of fetal fraction in that trisomic sample. But if you don't get that, then it's an indication that could be a mosaic change. So one of the questions that came up before is, you know, do you have a smaller placental element in trisomy 13, 18, 21? Or is it that they're mosaic? And I think both of those things happen. So this is a really nice paper from Bryson et al. That looked at the fetal fraction per chromosome, and it looked at some of the rare autosomal trisomies that we see, but also the live birth trisomies. I don't know whether you can see the chromosome 18. So if it's 100%, then that's what we would expect. 100% or more, that would be a full trisomy. And you can see 22 and 21 are generally full trisomies. Chromosome 18 is associated with some cases that are confined placental mosaics, or mosaics. The ones that you see all the time in the rare autosomal trisomies, 7 is clearly very often mosaic. And that's a finding that you see in CVS, and it's nice to see this finding in NIPT at the same time. But you can see that there's certainly with 13 some elements of mosaicism here, as well as 18, and really 21 and 22 are the only ones in this series that are mostly full trisomies. So the other thing you get, of course, is aneuploidy of all the chromosomes. If you look genome-wide, it gives us identification and help with our false positive diagnosis, and it gives us fetal fraction. I sort of purposely separated aneuploidy for all autosomes and rare autosomal trisomies. Rare autosomal trisomies is what you see the majority of the time, but occasionally you see multiple aneuploidies, and they have a different impact. So this is just a quick aide-memoire, and this is to show you the kind of extent of the different abnormalities that you might expect. And here are the trisomies. These are the rare autosomal trisomies. And these are what you expect other than the 13, 18, 21, X and Y. And about 12% of abnormalities are the rare autosomal trisomies. This is a slide that I adapted from Leif Page Christensen, and it's one of hers, and she had this nice table, and it shows the studies that are out there looking at rare autosomal trisomies. The actual number of samples in these studies is now huge. I think the largest studies are Pertil, which is just short of 90,000 samples. And you can see the prevalence of the rare autosomal trisomies between just below 2% to, I think the highest one is 9%. It might reflect the population studies, but you can see it's a reasonable number of aneuploidies that you might see once you start looking outside 13, 18, 21, XY. And then, the follow-up. Follow-up usually is with amniocentesis, sometimes with CVS, and if the follow-up is done correctly, it's also, there should be placenta taken at birth so you can start to see if it was really confined placental mosaicism. Clinical significance is, I think, largely sometimes down to interpretation. For instance, the last study here, the Wan et al., they followed up their cases and they did amniocentesis for almost all the cases. Hence, they saw very little confirmation. That's not to say that it wasn't true. It was confined placental mosaicism. It's just they say that they think, in their consideration, that there was very little clinical significance. I think, talking to the prenatal specialists, and I am not one of those, I'm a geneticist, I'm not a clinician, I think people have differing views of the clinical impact of some of these confined placental mosaicisms. And to me, reading the literature, it seems that there are certainly some clinical implications. The chromosomes that are affected, chromosome 7 in all studies is the most frequent. That is clearly associated with confined placental mosaicism. And you can use the analysis of fetal fraction of each chromosome to see that in NIPT. It's not always confined placental mosaicism, though, and it's really important not to just say it's a 7, it's confined placental mosaicism, but actually to look at the fetal fraction and try and assess whether it's fully trisomic or not. So that's the most frequent one. There was 2 series here in the Purtell paper that agreed very nicely. Chromosome 15, 16, 22, down to some really unusual ones where we got once or twice. The Bryson paper was very similar as well. 7, 16 being the most frequent. And what's nice is people using different techniques, large series, have found largely the same number of results, which is a nice indication that the field is consistent. We did initial assessment of 3,342 samples where there was no confirmed trisomy of 13, 18, 21, and we ran it through our pipeline. The numbers are pretty small, but clearly we found that chromosome 7 was the most frequent. Unusually didn't find that 22 was that frequent, but 16 was there. Trisomy 8 is quite often associated with maternal mosaicism, and that's something that would have to be followed up. But certainly, I think the initial blush is that we got roughly broadly similar results to the published papers, which is a good starting point, and is something that I think if we'd been in this field, we would have followed this up and seen how we compared to the other people in the field. The Purtell paper it's a bit small list, but it's useful to go through because it gives you some indication of the clinical consequences of some of these trisomies. So just going from the top here, this is true fetal mosaicism, UPD, intrauterine effects, normal live birth, and you can see that for quite a few of these, you do get normal live births. I'm trying to look at this kind of sideways, which is a bit awkward, but certainly, for instance, chromosome 5 here, largely associated with normal live birth, but you can't discard it completely. There was a fetal mosaic there. Chromosome 15, very strongly associated with early miscarriage, and I think that's really interesting when people say you look at rare autosomal trisomies and it has no impact. Well, clearly it certainly has impact on the prognosis of those patients at times. Trisomy 2 has been associated with UPD, and if you do get a rare autosomal trisomy of 2, you should really be looking for UPD to see whether that's there. But clearly, small numbers, but very interesting findings. And I think for the people who say there's no clinical impact, I think this kind of data, and the Purtell paper is a really good paper, starts to show that there is a clinical impact. The other thing you get is a really unfortunate incidental finding. If you look at all the chromosomes, it becomes not just a test of the fetus, it becomes a test of the mother. And this was well described first, really, I think, by Diana Bianchi, of a huge series of 125,000 cases, and they found 10 cases. And when they looked at these cases, there was multiple aneuploidies in the NIPT result, and they followed these up, and these were occult maternal malignancies. So these were ladies that were presenting without any indication, and mainly hematological, but definitely occult maternal malignancies. We have seen these, and this was just an interesting case to present. So this was a patient that asked for 13, 18, 21 plus microdeletions. At this time, we were using a test send out, that we sent out this sample. It went out, the test failed. So we asked for a redraw as your normal procedure, and it's really unusual, as Vincenzo said, if it redraw fails, actually, what is the reason of that? If the sequencing quality scores are good and it's worked on the sequencer, but the bioinformatics fail. Our external provider gave us nothing, and that's it. It's a redraw, and they didn't tell us anything. So we weren't really particularly happy with that, and we just were developing our 24 chromosome pipeline. So we looked at the 24 chromosome pipeline, and there were 10 aneuploidies in this sample. This starts to give you a different kind of issue. The patient has asked for 13, 18, 21. You just want to find out what went wrong with their sample, and what do you do? So in this instance, we just advise the patient to undergo further testing. They ask us for one thing, we can't feel that we can tell them something different. They had amniocentesis. It was a normal male pregnancy. They had ultrasound and an investigation. Unfortunately, the investigation just didn't go far enough, and at 36 weeks, the patient was hospitalized due to abdominal pain, and a large tumor was found in the stomach. And they have a C-section, and at the same time, the tumor was excised. So one of the incidental findings is if you're looking at all chromosomes, you are by accident doing a liquid biopsy. You're by accident looking for maternal occult malignancies, and that's something to consider as one of the, I'm not sure whether it's a negative or just one of the side effects of looking at all chromosomes. And that leads us to you develop a new test, you have new things you can look at, and as ever, you have new questions to ask, and what you've seen, and then what do you do? Do you report on the further aneuploidies, or do you just recommend further testing? And all we did in the cases we found was just recommend further testing, because we were only going to report what was required by the test from the patient. So just to sum up, really, the 24 chromosome NIPT has some real advantages other than just detecting rare autosomal trisomies. It helps you to look for the quality metrics, and it helps you to see whether you've got false positives and false negatives, because you can look at the chromosomes in detail in a subchromosomal fashion. You can look at the chromosomes that are used to normalize the test, and it gives you a better understanding of how the test works. You can look for copy number variations and see whether they're maternal. And also, if you look per chromosome and you see a consistent fetal fraction, you can estimate of whether you've got a placental mosaicism in the rare autosomal trisomy or the live birth trisomy. I am not a clinician, but it seems to me that the rare autosomal trisomies are useful for patient management. Just a personal opinion when I read the literature. Just last slide. This field is really, really moving on massively, and it's huge big data. And this was a publication in the last month or something like that, and it's genomic analysis of non-invasive prenatal testing, genetic associations, patterns of viral infections. I think the viral infections part is really interesting. the sequencing is really low pass, but when you've done millions of tests, you can really start to dig into the data. And actually, there's a screen there, but there's other screens that we can do in the future, and it seems like a really interesting field. So, thank you for your attention.